Thanks, everybody. I'd also like to thank Auntie Carol Curry and to acknowledge the traditional owners and pay my respects to elders past and present. I'd also really like to congratulate Cancer Australia on all the work that you're doing, and I think it's just fantastic that we're having this forum here today. Okay, I'll just see if I can... Okay, so these were the learning objectives to, I guess, to increase your awareness of risk factors related to cancer, including modifiable and genetic factors, to increase understanding of best practices for early detection of cancer, but the next speaker is going to be talking about screening specifically, and I guess increase our understanding of how a healthy lifestyle can reduce the risk of developing cancer. So I guess one of the things about talking about behavioural risk factors, and I think it's really important to maybe think about why we talk about risk factors, because if we're talking about prevention, we're talking about the things that we know are associated with causing cancer. And so it'd be easy to get up here and say, you know, don't smoke, don't drink, you know, exercise a lot, you know, eat healthily, have a balanced diet, go to bed early, lead a good life, and you won't get cancer. But it's not quite as simple as that. But we do know that there are a number of risk factors for cancer, and so we can talk about biomedical factors, we can talk about lifestyle factors, and we can talk about environmental factors. And I think we would concentrate quite a lot on some of those lifestyle factors because they are potentially modifiable. And we'll come back to some of these other things as part of the talk. Okay, I thought I'd just go and talk a little bit about biology because this is sort of a normal cell with nice cells, but when we have cancer, particularly solid cancers or epithelial cancers, there's often a change that occurs over time. So you see that the cells start to grow. This is what we call hyperplasia. They become dysplastic, and then you can actually get changes in those cells where you're getting some cancerous changes, but it's not invasive. And then cancer is when we actually get these invasive cells. So I guess the point of this is that there is somewhere in this sequence the opportunity to detect these abnormalities before we get to the point where there's invasive cancer. And normally we do have abnormalities in cells that occur, but normally what happens is that those abnormal cells get detected and they get killed off. And and we call that sort of cell suicide or apoptosis. But what happens once we get abnormal cells is that they don't get killed off and they start to divide, and so we get this sort of uncontrolled growth. And the important distinction really about malignant cancers is that they can invade neighbouring tissues, enter into blood vessels and metastasize through blood and lymph. So that's really what we want to avoid, and it's one of the reasons why what we're really hoping to do is detect cancers early before they have a chance to do that. Okay, so if we're talking about how do we do better in controlling cancer, obviously prevention is a really key part of all that. I think we'd all agree that prevention is better than cure. And we know that prevention measures are usually cost effective, as well as saving people a lot of grief and pain, I suppose. I think the other thing to note is that what you'll notice with many of these risk factors is that they're similar risk factors for many other diseases that actually have a very high burden of disease. So cardiovascular disease, diabetes, chronic respiratory disease and alcohol dependence. So all of these risk factors are exactly the same risk factors. So we actually, if we're working on prevention of cancer, we're actually doing better. We're getting a big bang for our buck, I suppose, because we're actually helping prevent other diseases as well. I think you can see various versions of this sort of graph, but it's really important to emphasise what a huge role tobacco has in terms of cancer deaths associated with lifestyle. I think some people would put this obesity and overweight at a much higher level than that, but we know that tobacco is absolutely huge. And we're going to talk a little bit about some of these other factors as well. So, Helen mentioned that cancer smoking rates have come down. If you went back to the 1950s, in sort of the non-Indigenous population, the smoking rates were over 50. So they've come down. So this graph only starts in 1997, and it was 24% of the population was smoking, and that's actually increased, which is pretty impressive. It's still coming down. And I guess this is just highlighting some of the things that have been occurring that have made a difference. And for a very long time, despite all that encouraging reduction in tobacco smoking in the non-Aboriginal population, Aboriginal smoking rates hadn't gone down at all. And again, I think you'll see a lot of these figures, and so I don't want to labour it too much, but this is the figure that Helen's already showed you, that in 2012 and 13, over 40% of Aboriginal people are smoking, but there is some good news that it's down. But I think what we also need to keep in mind is that actually the gap between non-Indigenous and Indigenous smoking hasn't really decreased that much. In other words, the non-Indigenous population is decreasing their smoking. So come on, you can do better, I think, but it's really very heartening to see that there has been some reduction, because for so long that was recalcitrant. Okay, so again, burden of disease study, and I think, tobacco is such a huge issue. A greater proportion of cancer is explained by tobacco compared with the total population. So they've got different figures there, but I think the real point is, if we're really going to win this, to prevent lung cancer, for example, but not just lung cancer, many other cancers have tobacco as a risk factor. Okay, so we mentioned overweight and obesity, and I guess it's worth mentioning that specific cancers have particular associations. So for overweight and obesity, cancer of the esophagus, colorectum, breast in postmenopausal women, the endometrium or the uterine cancer, and the kidney are all associated with overweight and obesity. And physical activity, inactivity is a major contributor to the rise in rates of overweight and obesity. When you have both a raised BMI and physical inactivity, it actually increases the amount of the attributable fraction of mortality due to breast cancer and colorectal cancer. And I think it's just worth sort of thinking that this is some other data that just basically shows that overweight and obesity increases with remoteness. And we know that there are a greater proportion of Aboriginal people living in remote areas. And we might want to think about why that is, and to what extent climate has a big impact on that, I don't know, but I think it does help sort of think about some of those places where we need to perhaps direct some of our effort. Okay, and again, this is from the same ABS as the tobacco, and I guess this is really, I think, quite alarming that in Aboriginal and Torres Strait Islander children aged 2 to 14 years, 19.6% were overweight and 10.2% were obese. So I guess we need to get those better nutrition, the concentration on increasing physical activity and improving nutrition. It needs to start at an early age. And again, very high rates of, in adults, very high rates of overweight and obesity, so 66%, so 2/3 of Aboriginal people. Oops. Overweight is one thing, but it's really important to remember that no matter what you weigh, physical activity matters. And so it's really good to get up, to take a walk, to just be physically active. And a couple of cancers in particular are important. It's important for colorectal cancer is very important, and breast cancer. So physically active women have a lower risk of developing breast cancer than inactive women, and we know that there are other cancers as well that physical activity seems to be important for. And I think it's also important to sort of remember that physical activity is good for lots of things. Again, it's a win across lots of other disease prevention activities, but even for people with cancer, there's some evidence that being physically active can kind of actually help with having a better outcome. Diet is obviously very important. We would encourage people to be reducing the amount of fat in their diet. This is maybe less important, but food preparation and preservation has been shown to be important internationally. And I think it's also important to remember that food contains antioxidants, and these are protective factors against cancer. And so the sorts of foods that we should be eating are going to be those ones that you've seen on traditional kind of food pyramids and the more recent sort of plate. But so vegetables, your green leafy vegetables, whole grain products containing fibre and citrus fruits. And again, I guess all this is saying is that what the data is that, well, we know Australia overall doesn't really meet these sort of nutritional guidelines, but if you look at Aboriginal and Torres Strait Islander people, they're actually doing slightly worse. So I think there is the opportunity to actually improve nutrition, and we know that in some parts of Australia that can be quite difficult. So I think we really need to turn our mind to some of those ways in which we work on that. Alcohol, the more a person drinks, particularly the more alcohol they drink regularly and over time, the higher their risk of developing alcohol-related cancer. And the alcohol-related cancers are largely gut-related, so head and neck, esophageal, colorectal and liver, and breast cancer as well. And there's a few reasons why that's so, okay? So, I guess this is where we get back to some of the basic biology about why these things occur. I said I would mention heredity, and I think we often hear about breast cancer as being heredity, and Angelina Jolie gets lots of attention and so on, but really it is important to remember that those sorts of mutations that cause breast cancer are really quite rare, and for breast cancer, for example, those genes account for less than 5% of breast cancer. But there are also some other conditions which are associated with cancers. Again, they're really quite rare, except perhaps for familial adenomatous polyposis, which certainly is something where we would be encouraging different screening if you had a family history. And I think it's worth just mentioning that family history means that you have probably 2 or 3 close relatives who have that same sort of cancer or a related cancer, or that they're getting cancer at a much earlier age than what you would normally expect. Oops, I think. Oh, okay. Okay, so again, we're back to these causes, and just, I know I need to be very quick, but it is worth just mentioning that in that environmental category, which was this one over here, we're talking about things like ultraviolet and ionising radiation. So everyone remembers sort of Nagasaki and so on, that there were, you know, when people get exposed to huge amounts of radiation, that they got leukemias and other cancers. So chemical carcinogens, so these are things that there used to be a lot of occupational exposure to things, but now we have much safer environments, but all of these things still can happen. We know that there is a risk that we're going to have a major increase in asbestosis and mesothelioma because of asbestosis. And biological carcinogens such as viruses, bacteria and parasites. So, and I think just to remind ourselves that these things can be synergistic, multiplicative, that they act in combination with each other. So doing what, you know, if you're a smoker and you're exposed to asbestos, that's going to be a lot worse. And that's true with many things, that tobacco actually acts in concert with other things, with alcohol use, for example. Okay, and I just wanted to go back to this sort of, to again talk a little bit about mechanism, because these are these things that we get exposed to, and what actually happens with these is that they will impact on the cell and generate free radicals, and that causes oncogenes to get activated. And so it's not a one-stage process. This doesn't just happen as a one-off. There's multiple steps in the causation of cancer. And again, I think that's quite important in terms of thinking about detection and the ability to modify lifestyle to prevent cancer. So it's not just one thing, it's multiple things. So, and it's really worth remembering that even if you've had risk factors for a long period of time, if you change behaviour, those risk factors will dissipate over time. So again, these were just the infectious causes of cancer, and I think there's two that we need to sort of draw your attention to specifically. One is hepatitis B virus. We have a very effective vaccine against hepatitis B virus, and that is hepatocellular cancer is quite a common cancer for Aboriginal people. So alcohol and hepatitis B are together a bad combination. And we now have a vaccine for human papillomavirus, so that's the HPV that causes cervical cancer and some other cancers. And again, we know that Kaposi's sarcoma was largely associated with HIV infection. So I've got to be very quick on early detection, but obviously the idea is to detect or diagnose the disease at an early stage. And there's two strategies. One is around increasing the patient's awareness of early signs and symptoms, so that they go and seek some help from a healthcare provider. And the other approach is screening, which is what Rosemary's going to talk about. So there's 7 warning signs of cancer, and I noticed that in this little booklet that was available out there, someone's done a lovely little fridge magnet which basically has these warning signs on it. So I think I see the Heart Foundation's got a wonderful, recognise a heart attack, call 000, etc. I think we should have these on all the fridges as well. So I'd really encourage you to pick up that. But I guess these are the things about change in bowel or bladder habits that go on longer than normal. A sore that doesn't heal, unusual bleeding or discharge, thickening or a lump in the breast or elsewhere, indigestion or difficulty swallowing, and we're talking about not just on one day, but something that you notice is a bit abnormal over time, obvious change in a wart or mole, and nagging cough or hoarseness. And I guess one of the problems for Aboriginal people is that they often have a higher burden of chronic disease, so they may not recognise these symptoms, and I think they're more stoical perhaps than some others of us. Oh dear. And if we're talking about delay in seeking treatment, this is a very nice diagram of everything that it takes around sort of help-seeking behaviour really to get to the point where you get diagnosis. And you can see there's lots of reasons. So if the patient doesn't notice their symptom, doesn't recognise it, that's the first step in this pathway. Then they've got to be prepared to consult a healthcare provider, and there's all of these things can lead to delay. The healthcare provider's got to get it right. They've got to recognise that that person has something and it could be cancer, and perhaps do a test or refer it on. So all of these things result in quite a lot of delay. So we really need to do all those things that Helen's been mentioning. That's part of health literacy, it's part of empowering people, it's also part of having culturally accessible services for people. I'm just going to finish up. Okay, So I guess the key messages are, we want people to find cancer early and survive. That does mean that they need to seek help if they have concerns, and that people actually often do have concerns. They have them for a very long period of time before they'll actually go and get help. So living a healthy lifestyle, you don't have to be perfect, but obviously reducing your risk factors will help reduce your risk of cancer. It's not an absolute guarantee, but quitting smoking is the most important thing that you can do for your health. Okay, thanks.